can predict your 6-month outcome by asking if you'll be better in 6 months. If I just have to ask you that question, and you say yes, what I actually do as treatment may not be as important as in building an alliance and keeping you engaged and getting you involved in something. I don't like to think about that too deeply because for 30 years I've been focused on becoming very good at manual therapy. But that too has its benefit, and I'll talk about that in just a second. All right now. So we just finished some work, a lot of work, 6 years, 400 people. It took a long time studying, comparing these complementary alternative interventions. We thought we'd compare spinal manipulation to spinal mobilization, 2 of the thousands of techniques to treat back pain. But we also included what we thought was a sham, and that was therapeutic touch. 6 years later, turned out patients wanted therapeutic touch, preferred therapeutic touch, expected therapeutic touch to help their pain. So we found no differences across any groups in the amount of pain relief. What we did find is that everyone who said their pain was better showed the same changes in connectivity in the brain. Right, so pain relief has a common pathway. How you get to the pain relief maybe not as important as what you think is going to happen during treatment. So what kind of explained this outcome? One of the directions we took was to think about provider bias. So just let me tell you, stick with me, tell you a story right now. When we started this study, we had a chiropractor working with us. I'm just going to make fun of Chaz for a minute. Chaz, hands of God, gay. And that was the persona Chaz had. 6'2" of Division I wrestler physique, hairdo, hands of God. His outcomes were pretty good. Didn't matter what Chaz did to you. You got better. The other trialist we had was Joel Bialowski, that some people may recognise that name. 30 years, fellow of the Academy of Manual Therapy, teaches all over the world. His outcomes were pretty good. Then we had some other poor sucker who was the third interventionalist, only 15 years of experience, but no strong preference for treatment. True equipoise. She believed that you could match the treatment to the patient and that all treatments had an effect. Her outcomes were the worst. So what we found, going back across a couple of our different studies, was that the provider's strong preference for anything, didn't matter what it was, if a provider had a strong preference for treatment, their outcomes were always better, didn't matter what treatment they were doing. So what we think that is represents this efficacy of the provider or confidence of the provider. When Charles, hands of God, gay, walked into the clinic, it didn't matter what Chaz was doing. He was able to work with you and probably do some of these intangible things, building an alliance, building trust. You became confident that Chaz was going to be able to make a difference for you. It didn't matter what he was delivering. And so that has gone back and explained a lot of our findings over the past 10 years. And so we have to kind of think about some of this. If you're reading a lot of research, ask, did they measure provider bias and efficacy? Did they control for what participants wanted and thought to get them better? And there's only a couple of studies that have done that and done that well.